Set, yeah.
Okay, David. Yeah. Dave?
Hi, Pauline.
Yes. Hi, Dave. How are you?
Say that if you want the speaker to be visible.
Oh,
So because you're Bonnie, it'll say
Oh,
that.
you said we begin?
Oh, you know, maybe it's changed.
yeah, he's gonna be able to change that bonnet. We could just say AdNA.
Your machine has connected to the internet.
I know, but I've got to find my URL.
That's good. That's
There you go.
easy.
So shall we start?
You introduce people and I will. Yeah.
Dave, where do you start? I just want to say thanks. Thank you.
Yeah. Thanks for coming.
All the years that you have supported.
Okay.
So Dave, tilt the camera up a little bit. So he gets a full head shot.
Okay. Have to go over. I have to cross the projector every time we do.
Oh, I see. Sorry, thank you.
This one,
Perfect.
this red dot is the camera. What we're doing.
Okay. Well, good morning from Chicago. This is the African Studies Association meeting, and this is a special Africa Now roundtable today, sponsored by the AdNA Network Forum, the Association of Concerned African Scholars, and the African Studies Center at Michigan State. I'm glad to welcome you to dealing with a tough topic on what did we learn from the infection of COVID-19 in Africa in dealing with the next pandemic, whenever that comes along. And what does that require of us in the US and more widely in the world? I'm going to very briefly introduce the members of the order they will appear in the roundtable, and then we'll get started. We're delighted that we're going to be chaired and introduced to the topic by Professor Bonnie Holcomb, who's a senior research associate at George Washington University in Washington in the ICPS Advocacy Network for Africa Forum, the AdNA Forum. Bonnie also is one of the founders of the Oromo Studies Association, has received honors for her work in that area. Bonnie will then lead us through our next speakers, starting from Nairobi with Pauline Muchina, PhD, who's Director for Policy and Advocacy for the Africa region at the American Friends Service Committee. And she has been for several years the chair of our AdNA COVID working group and represented us in the Citizens or COVID Roundtable and other organizations internationally and nationally, and will be speaking out of that experience. After we hear from Dr. Muchina, well, then I will be speaking. I'm a sociologist who's worked in order in Zimbabwe, Zambia, Kenya, and South Africa on environment and development issues of a range, and I've spent a number of years in this association as well. Our fourth speaker we're delighted to have is Matthew Kavanagh, the director of the Center for Global Health Policy and Politics at Georgetown's Medical Center and the School of Health. On the issues of vaccines in Africa, Matthew is one of the nation's most experienced experts with his background in political science and his work with the United Nations on UN AIDS and with various NGOs in the US and Southern Africa. He has just returned from Africa for pursuing the issues of vaccines and the communities there. After those three speakers will be followed by Imani Countess, the director of the Africa US Bridge Network. Imani has years of experience in Africa and recently in Zimbabwe. And as director of the Africa Bridge Project, has been leading those of us in the AdNA network as well and establishing partnerships to seek justice and peace and development in all of Africa. With that, let me turn the mic and the camera over to Bonnie Holcomb, who will introduce our roundtable for the day.
Thank you, Dave. Thank you to those of you who've chosen to be in the room and those who join by Zoom currently and in our future iterations. We hope to make this panel available on the AdNA website and beyond. So as Dave said, I'm Bonnie Holcomb. It's my pleasure to welcome you all to this much anticipated panel at ASA in Chicago. It's warming up a bit here. We arrived with 7-degree weather. So the event grows out, as Dave said, grows out of the work of AdNA, Advocacy Network for Africa's, primarily that of a working group. Now, AdNA, let us introduce, is a nonpartisan network of US-based organizations and individuals who maintain a significant focus on Africa and US-Africa relations in their work. So part of that was immediately after COVID, the formation of a working group on COVID-19, which was formed a week in the few weeks into the global shuttering of public life after the COVID pandemic was declared. The group was ably led by Pauline Muchina, who, as Dave said, is one of our participants today, joining from Kenya. We have great appreciation for Pauline, the leadership she provided in this, and engaging so many members of AdNA in the effort. People across the globe struggled to avoid passing a deadly virus while vaccines were under production. AdNA began advocating for equitable global vaccine distribution as early as mid-2020, long before the vaccines were produced. We anticipated obstacles and roadblocks, but worked to raise awareness of the need for justice in making vaccines accessible to all. We plan to continue this work in the next pandemic, which is why we're here. We know that something will come. So vaccines were produced en masse in record time due to publicly funded breakthroughs in medical technology and became available to the public in primarily wealthier countries in early 2021. In early 21, as these vaccines became an effective tool to reduce COVID-19 associated morbidity and mortality in the wealthier countries, the World Health Organization set an ambitious target to vaccinate 70% of the global population by mid-2022. However, as a shortage of vaccines that had been expected at the time that projection was developed, by July 2022, World Health Organization had to cut back their recommendations that all countries, including the Africa region, would get these vaccines and began to prioritize high-risk groups, including older adults and healthcare workers, rather than generally. By the end of 23, approximately 860 million doses of COVID-19 vaccine had been delivered to African countries, and 646 million had actually been administered. Cumulatively, 38% of Africa's 1.8 billion population had received at least one dose. 32% had completed 2 doses, and 21% had received the booster dose. Cumulative in some countries, less than 10% received 1 dose. One estimation says that fewer than 1 in 7 Africans received a single dose of vaccine. Indeed, at the end of 2023, nearly 1/3 of the people living on the planet had not received a single dose of COVID-19 vaccine. Now, I have a slideshow just to put these numbers in graphic form. And where's the PowerPoint? There we go. So here we are. This is a graphic depiction of what I just shared with you. The blue line represents the percentage who received greater than one dose, and the dotted line who received complete primary vaccine of the series. Another slide is the beginnings of by February of 2021, as they rolled out, the number administered to high income countries, as you see, and down here, what COVAX made available far down in the screen here. Our sources are Our World in Data. This is a proportion of vaccine doses administered by income level. And you can see the orange lower middle income by May 2023. The vaccination in African countries has been much slower than in any other region of the world. This is graphically shown here at the top: South America, Asia, Europe, North America, Oceania, Africa. So we have little known about the pandemic's true impact in African countries due to low testing and reporting. I think Pauline will expand on that matter. She's an expert on that at the grassroots level. By summer of 2022, less than 1.9% of COVID tests were conducted in African countries. The lack of access to hospitalization data for most countries and mortality statistics can lag for many years. We're blind in that area. The impact of what has been seen in official reporting is critical. A number of the serological studies by World Health Organization suggested that 65% of Africans had been infected by September of 2021. This would indicate that infections on the continent were 97 times higher than reported in confirmed cases over the same period. So that brings us to where we are here. The people who we have invited here will address, that's a little bit different than the order on the schedule, Dave, the way you introduced us. We'll discuss the shortfall of COVID-19 and other vaccines in Africa, the human costs of the shortfall, the need for global open sharing of patented vaccines in light of current epidemics of HIV, Mpox, cholera, malaria. This will include the causes of the shortfall of the pharma companies, resistance to sharing, the internal factors in African health systems, as well as the good news about vaccine mobilizations of WHO, UNICEF, Gavi, African CDCs. And we'll be concluding with what Africanists and Friends of Africa can and should take to the next pandemic, as the next pandemic arises. So we will start with Pauline, who is chair of our group, to examine the all-important internal African factors, on-the-ground lessons learned for Africa specifically, projects whose lessons, and project these lessons to current and anticipated epidemics, which can inform future advocacy. And then I will call on Dave Wiley to focus on the internal US factors, which affected the Africa experience. That is the global scientific, business, and political dynamics of COVID vaccine responses in the West regarding Africa and lessons learned there. He'll touch, and I won't steal his thunder, on the role of the pharmaceutical companies, particularly on the US political waffling and eventual reneging and the implications. And then we will hear from Matt Kavanagh as we look at one of the really the world's experts on looking at what HIV experience brought to the COVID response. And now we turn to him to look at what the COVID response brings to our future anticipated work, with an eye toward how this kind of information will help equip us for advocacy in a more effective and powerful way going forward. That's why we're here. So I will call on Pauline. And I hope Albert will put her on speaker view, but thank you very much for being here with us.
Can you hear me?
Yes, perfect.
All right.
Sorry to duck in front of
Good morning, everyone. Good afternoon, actually late afternoon from Kenya, my home country where I am visiting after some work travel in the region, and I'm staying here for the holidays and trying to avoid the cold weather. But I am so pleased to be with you this morning to share with you some of the thinking or some of the lessons learned in the continent regarding COVID-19. I don't have a PowerPoint presentation because I want it to be, I know Bonnie already presented some statistics that are helpful in what I'm going to be talking about as well. So I am not going to be showing a PowerPoint presentation, but many people expected Africa to be devastated by COVID-19. And to a certain extent, we were, because even though we don't know the statistics of how many people died in the continent from COVID because of lack of data, we know that many families lost their loved ones, and we know that the greatest impact of COVID in the continent was more to do with the economic conditions in the continent, and I'll talk about that a little bit better. But you know, even as the world was being impacted, Africa also was being impacted, and I lost 2 family members to COVID, my aunt and also my sister's husband. So it did impact us also as it impacted others. But when it happened in January 2020, I was in Kenya also for vacation, just as I am here in December, and then I stay over January. And I remember when it was first announced, and everybody was so like afraid, and I was too, because I was thinking, oh my goodness, with all the challenges we have in the continent, now we have to deal with this pandemic. And I was looking at our health infrastructure. I was looking at what do we have to really offer our people and to protect our people, and I was so worried. But it became so clear that the pandemic was not only going to ravage Africa, it was going to ravage the entire world. I left Kenya, I think it was on March 5th. And by the time I was leaving Kenya, it had already been declared a pandemic. And I traveled through Dubai and then to Washington, D.C. And by the time I was leaving the Kenyan airport, there was already people being asked to wear masks. And I saw people wearing masks here and there. And I was already hearing talks of maybe even a lockdown before I even left Kenya. But I left a very worried family, a very worried continent, a very worried country. And I arrived in Dubai and boarded at Emirates airline and realized that people were not wearing masks as much, but there were a few of us who had masks on. But imagine my surprise when I landed in the US and people were not wearing masks. I was like in a taxi with a taxi driver who did not have a mask, and I was wearing mine and asking him, why are you not wearing a mask? And he was like, why? And I was trying to explain to him COVID, and the government should already declare that people should wear masks. Anyway, I'm telling you that so that I can go into lessons learned. And the first lesson learned for me, and most health experts have also shared this, is the fact that African governments, especially the health ministries, most of them responded early. And they took the pandemic seriously, unlike the United States, where even the government was, taking it so easy and not requiring people to even wear masks. By even after the WHO declared it as a pandemic, the US government was still delaying. Anyway, African governments, especially some of the ones that started early, like Rwanda, Uganda, Kenya and others, they actually realized that this was a pandemic and it was not to be taken easy. And the other group or organization that took it seriously was the CDC Africa, that decided to start collaborating with African governments to really have a prevention strategy to help African governments. They knew Dr. Nkangasen, he is now at PEPFAR, but he was the CDC director, and realized very early on that this pandemic was to be taken seriously, and started bringing together ministers of health experts from all over Africa to see how Africa was going to protect itself. So we realized earlier on that strengthening public health system, which included Africa CDC and bringing the ministers of health together, was a priority. We also knew that there was a shortage of healthcare workers. There was a shortage for facilities to treat people if they got the pandemic. And we also realized that we did not have enough supplies in the continent, because we relied on China and we relied on others to produce medical products for us, including masks, including PPEs, including gloves, and including oxygen machines and others. And they were all not produced in the continent. They were all produced outside. What we realized very quickly, and it was a big shock to us, was that others were not willing to share, because they were also carrying a heavy burden for themselves. And frankly, some of them were just greedy. And we can talk about that later. So the first lesson learned is the public health system wasn't strong enough to deal with this. We also learned very quickly that we had shortage of workers. We also didn't have facilities and supplies. But we also learned very quickly that we had to rely on our past experiences: Ebola, HIV, malaria, tuberculosis, others, choleras and others, to be able to keep our people safe. So we started picking from lessons learned from those diseases. And one of the big one was role of grassroots initiative and trust building. And that came in handy because community workers came in handy. People, the chiefs, the local pastors, and others started helping people to learn about COVID almost immediately. And it didn't take long to realize that social distancing was necessary. It didn't take long also to realize, when it was announced that it was airborne, we realized that even that was even more dangerous than all the other diseases we had dealt with. Because Ebola was, you had to touch. HIV, obviously you had to be contaminated by fluids by someone who is HIV positive. For malaria, it was not transmissible. You had to be transmitted by mosquito. We learned very quickly that it was also transmitted by air. So the governments in Africa started lockdowns, and those were not popular with most people. And they had very negative economic impact on our people. And also, we realized that some people could not even social isolate because they lived in informal settings, and even people had small houses, and even someone with COVID could not be isolated at home. They had to be isolated at a government facility, which were sometimes schools, sometimes health specific isolation wards in the health ministries or at hospitals. And the hospitals started designating not just wards, but even some of the hospitals in Kenya and other countries were designated as hospitals for COVID. And that helped a great deal. But very quickly, the pandemic increased so quickly and started killing people all over the world. And we were listening how it was killing people in the US and how it was killing people in Europe, and wondering, how are we going to survive? But thankfully, we were able to survive. And but we also learned a very difficult issue And that was the need for self-reliance in vaccines. Because when vaccines became available elsewhere, they were not available in the continent. And there were most people like the US, some of the European countries like Germany, China, Russia, they were not willing to share their vaccines. And in fact, most African countries were not able to buy them either. They were not available and we couldn't buy them quickly as much as they were needed. We didn't have PPEs and we couldn't access them either because the rich countries were fighting over them in China. That also exposed some of the Western countries because they also did not manufacture these products in their own countries. They depended on China. And they were fighting over these products over there in China. And the money that they were willing to spend was more than most African countries could afford. Then we also realized, that we needed to rely more on digital innovations. Success of mobile platforms for health services, which happened, because people are learning about COVID from their mobile phones, not print media, but most people in the continent have cell phones, and those cell phones can be used to train people. So that was another lesson that we learned very quickly, especially for truck drivers traveling across countries, and they were monitored through their cell phones, and they were tested when they left, for example, Kenya, and Uganda Ministry of Health was informed, but that the truck drivers living in Kenya, either were COVID-free or were COVID infected. And the same thing happened. And, that helped a great deal because during HIV, the HIV pandemic, which we still have, was spread very quickly by cross-border truck drivers. So that was really encouraging. I did also mention lesson learned about how Africa CDC and other regional initiatives played a very important role. If they had not acted proactively and provided all the measures and tried to bring people to collaborate together, I think the pandemic would have been worse here in this region. So other lessons learned, we can discuss them, like I know that we talked a lot about the African family structure and how people support each other. And that's probably one of the biggest strengths that African countries have. Unfortunately, that is eroding. But that really helped us because if someone got sick, the person was isolated, the rest of the family designated a specific person who would take care of the person who was sick. And, I actually was so amazed by how people were even willing to live in a very tiny place so that they can help those with with COVID to isolate so that the whole community doesn't get infected. So I'm almost done with, talking about, I'm actually done with talking about the lessons, but I would like to talk about policy recommendations for African governments, but also for other governments and other international agencies that are helping African countries in this pandemic. And one of them especially is to strengthen health systems. As I talked about, they were collapsing, health systems were collapsing, or they were non-existent. The healthcare workers died in masses. We had doctors who died, specialists like cardiologists, neurologists, physicians. They died because they were at the front line of COVID. Also nurses and other healthcare workers. So we need to now strengthen our health system. And the way we do it is not only to allocate budget to health, which was already decided at the Abuja Declaration that each country should set aside 15% of their budget to address health services. And most countries do not implement the Abuja Declaration of 15% for health services. The other thing is to train healthcare workers, and many of them are trained here in Africa, and then they are exported out. So we need to retain healthcare workers so that when other pandemics come, we'll be more prepared than we were the last time. So this brain drain of healthcare workers need to stop. The other thing that we are recommending is expanding hospital and clinic infrastructure. We definitely have a shortage of health infrastructure, not the health hospitals, even specialized hospitals. We don't have them, and we need to change that. We also need to promote vaccine manufacturing in the continent itself. And we need to really support local production of medical equipment, treatment, like even testing kits. We did not have them. We were depending on China to provide them to us. We need to be able to manufacture those things here so that we test the disease and we are able to also treat with the products also manufactured here. The other thing we also want to recommend is building or fostering public-private partnership, because we realize that the pharmaceutical companies have a lot of power. And, you know, I know Dave will be talking about this because of the TRIPS waiver and the refusal even to share the vaccines that the partnering or even the knowledge of how to develop the vaccines that they came up with, which was saving lives in the US, but we did not have access to them. And our advocacy group, AdNA, we joined other vaccine coalitions to really fight and advocate for vaccines to be shared, not only for them, like the United States, to send vaccines to Africa, but also to push for example, all the companies that were manufacturing vaccines to share their knowledge of how those vaccines were manufactured so that African countries can develop them. So far, we've not succeeded very well. We only have 3 countries manufacturing vaccines right now in Africa. And we need to do more. You know, the COVID vaccines to be specific. That's South Africa, Senegal, I forgot the third one. But, you know, we need to be able to have each African country producing its own vaccines to save lives. The other one, you know, I will run very quickly through the other technologies because I think I'm out of time. Anyway, so
You have 2 minutes, Pauline.
2 minutes, thank you. So we need to establish a continent-wide medical stockpile so that we are not at the same spot where we were in 2020, where we could not vaccinate our people, we could not treat our people, even when treatment became available in the US and also in Europe and China and all of that. Here in Africa, it was still not available. And even up to now, if you get COVID and you go to a hospital here in Kenya, they don't have the COVID medication that they have in the US. So we are still at a loss. Anyway, so also we need to enhance regional collaboration. We need to have more, collaboration. We need to have a very strong Africa CDC with adequate resources. We need also to invest in internet infrastructure, especially for rural areas to have access to internet so that when a pandemic strikes, they can also be getting their information at the same time. So we need to leverage technology and innovation, and especially we need to expand digital health platforms for surveillance and telemedicine, because those were needed during COVID and they were not available here. So when you talk about digital health, someone will look at you weird, but people are getting telemedicine rather than presenting themselves at a hospital clinic and catching COVID there. If you had a heart attack, or if you had, obviously you cannot treat heart attack on a phone, but other ailments that could be treated digitally. So we need that. Anyway, I'm gonna stop there because I hope that we can have more conversation to discuss more, especially on advocacy, so that we can have more people who are advocating on these issues, because we need to also focus on marginalized populations, especially refugees and people, those who are living in conflict zones. I work mainly on peace building, and during COVID, some of the people who were caught in conflict got exposed to COVID because they were either in transit or didn't have anywhere that they could, hunker and be saved from COVID. So we need also to be focusing on those marginalized population. Women were the primary caregivers, and many women died because of COVID, because we have failed to provide gender-sensitive approaches to address vulnerabilities of women and girls when there is a pandemic. And of course, we need to ensure equitable access to health for all. And I'm going to stop there, and we can have a conversation later. Thank you so much. Bonnie, can you hear me?
Yes, thank you, Pauline. Dave is going to the podium.
Okay.
There
Yes.
he is.
Thank you very much, Pauline. That was very, very helpful, especially the list of needs that we needed to attend to, the positive role that the African CDC has played, and we'll come back to that more. But I just want to start with a very personal story. I think one of the most memorable days that I remember and events I remember in elementary school in a little coal mining town in southern Illinois where I grew up was that day that the teachers lined us all up in a column to go down to the gym where the air reeked with isopropyl alcohol to give us a hint of the terrors of the needles that awaited us, and the columns of wailing children then that stepped up to the nurse in order to receive the vaccination. I was there too, and I'm glad for that. So here, 80 plus years later, I'm still around thanks to those vaccines that they forced upon us. And I'll just mention the end of that story was we all cheered when Jonas Salk and his colleagues created the sugar cube oral vaccination that got us away from the needles, at least for a little bit. But our community then, interesting, had, as far as I could see, no public anti-vaxxers. And I found that was also true in Lusaka, Kitwe, and Ndola in Zambia as well, when I was there for a year helping the Zambian government to get a World Bank loan with information, social information on the populations in the squatter townships, where we found a number of stories. When we asked the question, what is it on this list from the government that you want most of all? You want a community center, better schools, more teachers, better roads, tin for your roofs. What is it that you want most of all? And the item that popped out of the survey of 3 cities was health. And along with that, many stories of parents who took their few kwacha to get a taxi to get the kids across town when UNICEF showed up with the vaccinations for German measles, for DPT, and so on. And now, increasingly, I understand in Malawi for malaria as well as one of the primary cities. Anyway, so wonderful vaccines. How wonderful they are reflected, from what happened when we didn't have them during the so-called Spanish flu in 1918 to 1919, which circled the globe in about 4 months to kill 21 million people. In the US alone, there were casualties of more than 675,000 people lost to the flu. And the pharmaceutical companies did work around the clock to come up with a vaccine to fight it. But in fact, they were too late, and the virus disappeared before the vaccinations even got there. And the world had paid the price of 21 million people dead from the flu at that time. Indeed, The Lancet has published in May a study that says that vaccines against the 14 most common pathogens have saved 154 million lives over the past 5 decades at the rate of saving about 6 lives every minute around the world, and has cut infant mortality, especially by 40% globally, and in Africa by 50%. So the UNICEF program of vaccinating about 1/3 of the children globally has really been a huge success. Bonnie and Pauline have showed us the results of what happened though when with this COVID vaccine, suddenly a miracle being developed in a very, very short time, perhaps of only a year after all the background research was completed, was a shortfall in Africa. And the story there is the shortfall was reflected in that East African proverb that when one sets a portion for oneself, usually it's not too small. And it was not too small for the wealthy countries who, with their purchasing power, got to the head of the line to monopolize the supply and got early delivery as well, and was extremely slow to respond to the COVAX request for assistance in Africa. In fact, high-income countries in EU and the US and Canada promised to come up with 2.7 billion doses by the end of 2022 at the beginning of the pandemic. In fact, they only came up with about 2/3 of those doses to actually deliver to Africa, with the withholding by Pfizer and Moderna of the Myrna vaccines. So where does that leave us? There was a moment of health hope, which came along on May 4th, 2021, when Biden, to our absolute surprise, announced that the US would support the request from South Africa and India to give a temporary waiver for vaccine patents. And Catherine Tai, our World Trade Organization, took that word to the WTO. What we didn't know was that in the background, there were 700 plus lobbyists in Washington, D.C. from the big pharma companies. 700 plus 55% are former US government employees who were there very, very quickly to say, let's consider this. We really need more money at Pfizer and Moderna and J&J and the others in order to do research. And if you take away our profits, maybe we won't be able to come up with an answer to COVID for boosters and the like in the future. So it could have been a different story. This was not a new idea, by the way, to agree with sharing of vaccine patents, because back in the 1980s, Australia had inserted in trade regulations the granting of exemptions to patent laws for vaccines very specifically. And the AMA Code of Ethics says that physicians may ethically patent their medical innovations. However, they should not use patents to limit the availability of medical innovations to all people. So the patent system requires full disclosure of the invention, enabling others to replicate it and to create it to answer the need. So, but the pharma companies said no. We don't, I'm hoping maybe Matt can give us some inside reflections on how it happened, that it was the UK, Germany, Switzerland, the US, and their pharma companies all opposed Biden's idea. We suspect that there was quite a lot of activity in the Senate, especially for those senators who might control. And there was a letter from 6 senators sent to President Biden that Tai and he, in this announcement of giving temporary access rights to the 121 manufacturers in the global South that were capable of creating a COVID vaccine for their own populations, that they actually suggested that Tai and Biden had violated the expectations of protecting intellectual property rights in science as a way of engendering innovation. So very quietly, in a way that was not announced, the U.S. proposal was shelved for further discussion at future meetings of the World Trade Organization. And I'm going to, in a minute, ask for Pauline to come back and tell us what she saw as the U.S. Vaccine Alliance people got together, Pauline being the representative from AdNA to that. So the very disturbing thing in a new study, there's a suggestion that the creation of the vaccines actually came from a huge investment of public funds, but the profits have all been going to the private stockholders and the executives of the big pharma. The most recent study suggests that 98% of the research and development cost of developing the COVID vaccines, earlier estimates said it was 92%, came from public sources. And so, big surprise, the 700 lobbyists in the House and the Senate really were stood up and got Biden not to propose the support of the South African India TRIPS proposal. By the way, I can never remember the name. TRIPS being the trade-related aspects of intellectual property rights, a complicated name for saying, don't let those 121 global South manufacturers get our patents or our formulas to create their own. We'll provide them with plenty of vaccines. Thank you very, very much. And the level of the vaccines at retail was $35 to the U.S. government and others, which the value of which many of us received, $35 a dose of a vaccine that it costs about $1 to $2 to actually manufacture with the formulas they had. So the issue that I think faces Africa and us is it's estimated that we're going to have another pandemic of some kind, probably within 10 to 40 years. The best guess is it might be 20 or 30 or less. It could be a day after tomorrow that we get it, as the lack of vaccines in the global South has created the pool in which there can be the frequent modification of the gene structure and the avoidance of being susceptible to the vaccine. So it could be the Nipah virus, it could be Ebola and Marburg viruses, it could be the SARS, it could be the Zika, it could be anything else that are waiting to infect us or our livestock, by the way, as well. But the corporations are not willing to do this, and poor corporations, you know, the CEO of Pfizer with an annual salary of only 24 million a year and a net worth of several billion, and the announced earlier this year that the $35 retail price per dose would be raised by Pfizer to something like $135 per dose. And with all of that, it's not surprising to see that in the Forbes list of new millionaires this year, that there are 9 new, quote, COVID-based billionaires with net worth between 1 and 4 billion each, including their stock options as well. So this is capitalism gone wild and a unique opportunity. And it now is, even the Lancet is publishing letters from physicians who are saying that this is apartheid vaccines. And it's time for us to take that on. So what do we need to do in dealing with this shortage of vaccines for the world, which creates new viruses for us as they are not with a shortage of vaccines? We need, as Pauline has suggested, to strengthen the health institutions and the personnel in Africa and the rest of the global South. Nigeria, interesting, I just read this last week, has 125,000 cancer cases that they are trying to treat with 70 cancer specialists in the Nigerian health system. 70 specialists for 125,000 patients. And virtually in the survey, virtually all of those oncologists in Nigeria have said that they are eager to go to the UK, US, or Canada. And a great chance that they will be lost. So we need to go back and to support Biden and the few days that he has left, and Catherine Tai, our WTO representative, to go back to say we want the TRIPS exception for vaccines, period, and not just COVID, but all of those other diseases that are likely to engulf us in the area. That is not just philanthropy and goodwill for Africa. That's self-preservation to avoid the creation of the new viruses that will circle the world once again. We need to get partnerships between our medical schools, of those of us in universities, and the African medical schools in order to help deal with this shortage of physicians that has popped up. We now have 5,500 Nigerian physicians practicing in the US, according to the AMAs. So, and even more are coming. And it's even worse with nurses. The Philippine connection for nurses is not answering the need. So we need to find ways to not only give the patent exceptions, but to provide the technology and the advice from our vaccine experts to those manufacturers in Africa and the global South. So at the end of that, then, we need to rise up. We all got caught unaware when the Senate started their conversations to negate Biden's decision, saying he made the wrong decision. We need to organize among our organizations, starting with the Association of Concerned Africa Scholars, AdNA, the Amnesty International, and the other large NGOs that favor the Help for Africa, to see that we actually get ahead on these needs of Africa and the development of new vaccine access for the whole world. And if we don't, we will be the victims of that. Our health is on fire. The viruses could overcome us all. It's the most dangerous enemy. It's the most biggest source of insecurity in our, not the military threats, but the threat to the health systems and to the people of the entire world. With our house on fire, our neighbors may ask us, where were you when the decisions came? Where were you when Biden was, or Trump, or whoever is making the decisions, is told that we can't agree to the TRIPS agreement to free up vaccine patents to the world? Thank you. We introduce Matt Kavanagh, our specialist from Georgetown, just returned from Africa.
Hello, everybody. I'm going to just move this slightly, if you don't mind, because I can't quite. I'm not good at standing right behind a podium, so All right, let's see if I can make the magic work once again. Amazing. All right. So I'm going to talk. I would like to just make that okay go away, but I'm going to just give up on that idea. So I'm going to talk a little bit about a couple of different pieces in terms of kind of how did we get here. So it's been really nicely described, kind of what happened during COVID, and how did that result in the kind of map that you saw being displayed, the kind of math you saw being talked about, but also the experience you heard from Pauline as we go. So I want to go back for a second to HIV. And I want to start with this core question of what does the process look like that's gotten us to the point where today 22 million folks in Africa have access to HIV treatment that is effective, it is cutting edge treatment, it is happening. But I want to point out the damage that was done in that lag beforehand. And so this is a graph of something that just came out. It's a paper that we just put out, and I'm going to talk about the kind of the pieces, some of the pieces later, but I want to talk about this piece right here and this piece right here. So when ARVs famously were kind of discovered and uncovered and developed, we had a 10-year lag from 1997 until 2007 before we had serious uptake on the African continent. That 10-year lag resulted in 12 million deaths. But it also, because ARVs stop HIV transmission, resulted in millions that we have not yet counted new infections. We have today a continuing AIDS pandemic, in part because we refused to treat it early. And in fact, you can see that in these graphs here. So that when HIV hit, and in 1997, when the new medicines came about, what we saw in the global north, the left is North America and Western Europe, was a massive decline in new infections and in deaths. This is deaths. What we saw on the African continent, on the other hand, was continuing rising deaths every year more than the past, despite the fact that there was effective treatment. That was deeply avoidable, and it was because the drugs were too expensive and there were too few of them, and they were monopolized by a few corporations in the global north. The result of that was a massive battle that put kind of four things on the table about how do we fix that in the future. Activists, governments, communities all came to the fore to create a new model, to demand that we have to never do this again, where we refuse to share technology and have millions of people die. And there were four pieces of what developed, because ultimately what happened is that we did achieve 22 million people on HIV treatment. And the four elements were: one, the use of law by national governments. Governments on the African continent and in low and middle income countries around the world took action to compel the sharing of technology. They issued some of what Dave was talking about, compulsory licenses, and used other flexibilities entirely legal under trade law to force companies to share the technology so that they could buy generic versions of those drugs. Had they not done that, there was no point at which companies just said, oh, we would love to share the technology, or we would love to reduce the prices. That never happened, right? What happened instead is they were threatened with losing patents, and they were threatened with kind of we will compulsory license, and that meant that they did reduce their prices, and they did voluntarily share their technologies so that they could have some level of control and engagement. And ultimately, HIV continues to be incredibly profitable for companies in the global north, but also for producers and generic producers in the global south. Now, would I prefer a nonprofit model of drug discovery? Yes, that would be great. But living in the capitalist world that we do, the fact that we actually have an ecosystem that's working matters a lot. The second thing that happened is that we created a voluntary mechanism for sharing technology. So the medicines patent pool was created, a few other things, so that companies, when they were pressured, could say, yes, I will voluntarily share my technologies. And today, the majority of people living with HIV around the world are on a medicine called dolutegravir that was shared by its maker, ViiV, into the patent pool because they were pressured to by activists, by the UN, by governments, and they shared the technology, and that's now made by companies in India, South Africa, Egypt, Thailand, Brazil, and it's available everywhere. So that decentralization allowed for technology transfer, allowed for companies to be set up. In Brazil, it's a semi-state-owned company. In South Africa, it's a private company. In India, it's a series of private companies, but they make the drugs today. It's entirely possible. And then, of course, massive international funding. So we figured out how to do this. This was not born out of success. This was born out of failure, but we figured out how to do it. And the price of ARVs, under the pressure that we put, right? This is the point that I was making. The price fell by 99%. And it went from 100,000 people on the continent to 22 million people on the continent with cutting edge treatment. So this is entirely possible. This idea that it was complicated, yes, it was complicated, but did we do it? Yes, we did. And by 2008, we had a model that worked. Then COVID. And so we've heard today the questions around kind of what happened when it came to the access to vaccines on the continent. But the point I want to make is that that model was entirely available. It was not unknown. It was not surprising. There wasn't some surprise that companies monopolized the production. It wasn't some surprise that high-income countries did not willingly share. This should not have been a surprise. And yet somehow we fell globally, global leaders fell for the promises that were made. And so this is a year, like this is a few months in. This is before there was ever a vaccine that was effective. This is Ursula von der Leyen of the European Union, and a variety of people you may well recognize. Justin Trudeau, who decided to grow a beard during COVID, which is my favorite thing that he did there. And they all got together and did a giant promise. Don't worry, we're going to treat these vaccines as soon as they're developed as a public good. Now, this is one thing just speaking, because we've heard a lot about this question of kind of, who had access. But speaking to what Pauline was showing, this question of like, was it that Africa didn't need access? That was a narrative that was around. Actually, somehow it's a young population, it's okay, there's not that many new infections. What we look now, if we do an analysis of excess deaths, which is just measuring how many deaths were there this year that you would expect to have the next year, you expect to have the next year, nothing changed between 2018 and 2021, right? There was no massive decline in life expectancy besides COVID. And so you can attribute almost all of those deaths to COVID. And what we see is that actually many countries were among the hardest hit from COVID, not the least hit by COVID. And so this idea that somehow the African continent didn't need vaccines was in fact a huge misnomer. And so why did we end up, despite having this global leaders jamboree that happened online and Zoom, right? Even though we did that, why did we end up with such complete failure that you've heard already when it came to access for the continent? Well, my argument here is that there are kind of one big reason, which is that we ended up with dueling law and policy paradigms. You had one law and policy paradigm that took hold, that was what I call the demand-focused voluntary paradigm, right? Which was basically saying the only thing we really need from those four things from the HIV model is the funding. We're just going to buy vaccines. As long as we have the funding, that's what we need. But remember, I told you that the drug companies never in HIV voluntarily shared their technology. They never reduced the prices. They never made enough in the global north to serve the entire world. It's never happened. And so an alternative paradigm also existed and was argued for by African leaders and by others that actually followed the full AIDS model. It just wasn't listened to. And so here is the demand-focused voluntary model. I call it the demand-focused model because the idea is if we can just pool demand, if we can say, let's just buy together, let's say the whole world will buy vaccines together, we'll pool our money, and yeah, some high-income countries, you can go off and buy your own, but all low and middle-income countries together will pool our demand, we'll do pooled procurement, we will negotiate with those companies, and so they created the ACT Accelerator and the COVAX effort. Now, I will point out to you that this is who came together to create the COVAX model. Literally with like no compunction. And I just like, sometimes I work in global health and I think to myself, like, how do people like wake up in the morning, look at this slide and think to themselves, yeah, that looks like the right group of people to figure out how Africa could get access to vaccines. And yet this is who the global health community came together to do under the World Health Organization leadership. And with Dr. Tedros out there front and center, adore him in many ways, using that kind of, that model and that imprimatur, they launched the ACT Accelerator under this idea. And it was a market-based way to scale up access to vaccines globally. What was their legal approach? Well, the legal approach was not to make any binding agreement among states. They said, we do not need to do that. We do not need to agree as countries to do anything. We just need to agree to pool funding. Companies can hold on to their intellectual property rights. That's not a problem because the IP is not going to be the central challenge, which actually kind of turned out to be true, but hold on a minute. It was up to firms to decide who to sell to. Pfizer got to decide who it wanted to sell to. Moderna got decided who it wanted to sell to. All of the different Johnson & Johnson decided. The important point here is that at no point were governments the actual decision makers of which countries got how many vaccines on what timeline and in what amount. That never happened. It was never the World Health Organization that decided that. It was company CEOs that every single time were picking up and looking, which order shall I fill, on what timeline, at what price? That was the entire global mechanism for allocating vaccines. That was the model. And the idea was that you could pool money and then buy it through the COVAX facility, and COVAX would be able to figure out which orders to give. And this was kind of talked about as this unique global public good. I will not ask if there are any economists in the room, but I will say that Ursula von der Leyen's understanding of public goods is slightly problematic because that's actually called club goods, right? That is literally like, you've got a dose of a vaccine. We can't share that dose of vaccine. I can have it or you can have it. We cannot possibly treat doses like a public good. And not surprisingly, the result was this. So this is a picture of how many doses per person were procured within the first year. So COVAX was set up. It was supposed to get 2 billion doses out. It missed that mark by over 50%, right? And in the end, in a year in, the United States had procured many, many more doses than its entire population. Canada had procured, actually, this is my favorite, the man with the beard, right? He procured more doses per person than any other country in the world. Canada, those nice Canadians, they're just so nice and they just seem like they're gonna come through. But actually, they procured more than anybody else. Meanwhile, every continent every country on the continent, with the exception of South Africa, was unable to even make a contract for enough vaccines for its people. Why? Red signifies fewer than 2 doses per person. So blue is more than 2 doses per person. Red is fewer than 2 doses per person. So why? What I was saying before, how were vaccines allocated? Vaccines were allocated not based on need, but based on your economic, legal, and diplomatic power. The United States is the regulator of Pfizer. Pfizer took the United States very seriously and filled Pfizer's orders first. The UK, Germany, all had vaccine manufacturers based there. They were able to do it. A variety of countries, Israel was able to procure using its diplomatic power, right? A variety of countries were able to do so. And so if you look across the world, this is a map of economic power. This is not a map of population or of need. And not surprisingly, if you actually look back, countries in the global north were not saying we will share our doses with Zimbabwe and Malawi and Nepal. They weren't saying it. They weren't saying you will have to wait if you are a young person who can work from home until we cover the health workforce around the world. They were not saying that. They were saying that on Zoom calls. And then at home, they were saying absolutely everybody is going to get vaccines. And of course they were. What government in the world doesn't tell your population in the middle of a pandemic, of course, we're going to cover you all? That's a political imperative. Nobody's going to do that. And so this entire model was built on the imagination that somehow countries were going to act in ways that they never have before when faced with an emergency. Basic political science shows us that actually when there's a public health emergency, when there's any sort of emergency with an existential crisis, countries act in their self-interest. But there was a model that actually was out there proposing to do something different. And so you saw at the time what I call the supply-focused, openness-focused, much more based on the HIV experience, that focused not on doses, but on technology. And focused on the idea of using state power and law and the mechanisms that are within the trade agreements that exist in order to share technology. And so folks called for this in the pages of the Financial Times. Folks called from it in a variety of places. But of course, none of these folks were in that nice picture that I showed you before. This legal approach, the idea is that it would pool intellectual property through the what was called the CTAP at the time. They would set up a technology transfer hub. Funny fact, Moderna was massively able to transfer technology. It just was only able to transfer it to Europe somehow. So they told us throughout the pandemic, it's so hard to transfer technology. We can't figure out how to do it. They hired a company called Lonza. Within 4 months, They bought a factory, refitted it, built from scratch an entire line, and were pumping out millions of vaccines in Switzerland. Boom, 4 months from the time they did the contract to the time it was there. The whole point of mRNA when it was created, literally, you can go back and look at these amazing slides presented at conferences in which they said, you know what's amazing is you could transfer this around the world. It's super simple. It's a box. You take it, you move it, boom, you can set up a whole new thing in an emergency. That was the whole point of mRNA. So folks said, look, let's do that. Let's use the promise of technology. Let's transfer technology. Let's set up factories around the world. Let's have an agreement, says the president of Costa Rica, between countries to share technology now, before we have a vaccine. He proposed this. He said, right now we have no vaccines. Let's agree that whoever finds the vaccine, we will share it with everybody. But the problem was, 2 minutes here. Problem was two things. One, we had the dominant paradigm that assumed this paradigm, sorry, the newer paradigm assumed that there would be vaccine technology. It said anytime the question is, will Americans and Europeans compete with Africans, Africans will lose out when you create that as an international structure. So why would we imagine that this time would be different? And it also assumed that we were not going to have some massive international norm that was going to make rich countries act differently. And so these two things could have been complementary. I want to point out that the United States used both mechanisms. It both procured lots of vaccines, but do you know what it did when one of the companies needed more of something? It used a compulsory license. It allowed Moderna to use technology that did not belong to Moderna because Moderna needed to use it to produce vaccines. So the United States actually combined these in order to get drugs to our people. But fundamentally, in the end, what I want to argue here is that we did not see a competition of ideas. We did not see international negotiation. Instead, you ended up with two parallel tracks. You had some folks working on this idea of an openness paradigm, but that group that I showed you at the beginning went off and created a new structure called AdNA, where they didn't have to negotiate with low and middle income countries. There was never a meeting of the ministers of health of African countries and the ministers of health of the OECD to hash it out. It never happened. That is a failure of global governance. And that is what I think people are waking up to at this point, because that's how you end up with this map. Now, I want to say two more weird stories, and then I want to close. One exciting story is that in HIV, the successes that we have had are under huge threat. Because yesterday, while I was on a plane, Science Magazine named the breakthrough technology of the year long-acting HIV treatment. This is an injection you can take twice a year, and it stops the HIV virus transmission. So you can use it if you are HIV negative. You take it, you get access. Twice a year, 0 transmissions in a South African study, 0. This is the closest to a HIV vaccine we have ever had. You can also use this for treatment. And so in the United States, they're starting to use it where people take an injection a few times a year and then never have to take a pill again. This technology is coming out, but do you know what's not happening? We're repeating this same cycle again all of a sudden, where it's going to be 10 years before we get access to this newest technology, because the companies are seeing that they no longer have to follow the model that they were following before on HIV, because they learned from COVID. We don't have to do that anymore. And here's what else is happening. Let's talk about Mpox for a minute. Where Mpox, when it broke out in the global north, in Europe, in Africa, or Europe, in Asia, or Europe, North America, and a little bit in Latin America, what you saw was the declaration of a public health emergency of international concern. And it turns out that smallpox vaccine works against Mpox. And so in the United States, where there are hundreds of millions of doses of Mpox vaccine or of a smallpox vaccine, it was simply rolled out in the United States. It wasn't that dramatic, and it stopped the outbreak. But then it turns out that in January, February, March, in the Democratic Republic of Congo, there were Mpox transmissions happening left, right, and center. And in fact, what we saw was that at the time, there were more Mpox cases and deaths in the Democratic Republic of Congo last year than there were in the entire rest of the United States. But do you know what they weren't? They weren't laboratory confirmed. And so the World Health Organization failed to report them. But in fact, they were growing and growing and growing. And so what we see now is a new declaration of a public health emergency of international concern. So let me close by just saying this is the negative, and by the way, there are no vaccines. That's the upshot of the Mpox story, right? Those hundreds of millions of vaccines, smallpox, they are currently sitting in the CDC laboratory, in CET stores, because maybe there might be a smallpox outbreak in the United States someday, whereas right now people are dying and need access to them, not rolling out. So here's the upshot. Sharing is not going to happen, period. Pauline was right. It is about self-sufficiency. Drug companies are not going to reduce prices. So slowly leaders are beginning to shift. And so there's work on a pandemic treaty. There is work on an mRNA hub in which in South Africa, they've reverse engineered, because it turns out that there are brilliant scientists who can do so, reverse engineered the mRNA vaccine, and they are making it and sharing it with other countries in the global south about how to make it. And finally, at the G20 this year, Lula, along with Cyril Ramaphosa, who's taking over the G20 presidency, announced a global coalition on local and regional production. So things are happening, movement is happening, and change, let's just hope, is possible. Thank you.
Thank you. This panel is as good as we expected. Really, very, very excellent presentations. Thank you, everybody. So our gift here is that Imani Countess, prominent member of AdNA, is going to serve as our discussant, raising the first questions, and then I hope asking some of the panelists to raise questions to each other if that, if that is appropriate. But welcome, Imani, Director of the U.S.-Africa Bridge Building Project.
Thank you, Bonnie. Thank you very, very much. I have to say that I am a bit stunned. This has actually been, without a doubt, one of the best presentations that I've participated in as an audience member, right? In this year in at the African Studies Association meeting. I really want to thank Dave and Bonnie, Pauline, Matt, and the AdNA team for pulling this conversation together. I'm particularly appreciative of the fact that there's opportunity created for online participation, and that as a result of the Zoom platform, there'll be future access through video distribution. All I could say when I was listening to all of this was, wow. I was just particularly struck by a couple of points that I'll try to quickly summarize, and I think that I found to be incredibly important. The first is the recognition of the early development, early prevention strategies in Africa in collaboration with Africa CDC. Also, the recognition of community engagement, grassroots engagement, creation of the sanitizing. Pauline didn't mention this, but I remember seeing this when I was in Africa, the sanitizing stations made by grassroots peoples. We talked about, or presenters talked about, the failure of global governance. And also the need to to mobilize Africa's resources for domestic investment. Less that phrase in particular, more a recognition of the need for Africa to strengthen its health system and to create manufacturing capacity and so forth. But in order to do that, right, Africa has to have money. Africa has money. It's just, for the most part, being stolen, largely through a process that we all know as illicit financial flows. We also talked about this, Dave in particular, the emphasis on profits, the pharmaceutical company emphasis on profits and the lobby machine that works on their behalf, situated within a global economic architecture that is designed to protect and advance those interests of vaccine apartheid. I think as we begin to talk about what we've learned from the COVID experience, it's really important to locate all of that in our current reality. And while I have not read anything from the incoming administration on their Africa policy or global health policy, I did build up enough nerve to read a few sections of Project 2025, which is sort of the framework. And I think if you read those short sections on Africa, mainly located in the sort of State Department and USAID sections, the emphasis that Project 2025 lifts up are one, building relationships with countries that are friendly to the US, cementing relationships with countries that are friendly to US business interests, combating Chinese influence, mainly around the access to minerals, and supporting the expansion of Christian nationalist evangelicals that are bent on expanding attacks on social and cultural issues, which is mainly really code for opposition to rights-based and LGBTQI protections. So fundamentally, if you look at what they're proposing, advancing sort of narrow US-centric interests, the subordination of Africa's efforts to use its resources for development, subordinating Africa's interests in fair and sustainable trade. In essence, we're looking at the same US-centric, transactional, business-focused policies that have been in practice for decades plus, to varying degrees, centuries. There are, however, very dramatic differences today. First and foremost, this globe is facing an existential crisis in terms of climate. And we're looking at an incoming administration where a majority of the members of the cabinet do not believe that the climate crisis exists. We're looking at a political landscape that threatens the foundations of liberal democracy and rule of law in the United States. We're looking at an incoming administration and the growth in the US of racism, misogyny, xenophobia, that resonate with large swaths of the American public. And we're also looking at the growth of white nationalists, neo-Nazi, and far-right reactionary groups in the United States. The Southern Poverty Law Center reports something like over 1,430 hate and white supremacy groups in the United States. So we've learned through our presenters sort of a roadmap of how we could advance progress around the next pandemic and public health in Africa. And yet here we are in this moment where our ability to do those things is significantly compromised. And so I think that for me, there's two sets of questions. One, I think, is sort of to lift up what Dave challenged us to do, which is to figure out how in the next 35 days or so, we could join forces with organizations, legislators, and others who might have the capacity to force the Biden administration to do what it promised to do. And then secondly, for us to begin to imagine what would it take, what will it take for us to really begin to put in place the strategies and the collaborations that will enable us minimally to hold the line against these very extremist forces, and ideally to be able to make some progress around putting in place what's necessary to truly ensure that we not only have learned from COVID, but that we're building the infrastructure to prevent the next pandemic. So again, this has been a phenomenally good conversation. I'm still myself a bit stunned by some of what's been offered, because much of it I did not know. And I want to thank everybody, all of the presenters, for the incredible work that they've done. Thank you.
Monty, you had 15 seconds left. Hey, Monty.
Well timed.
Yes, so I would like to invite the presenters to ask each other questions if you have questions. Dave said he had some questions for Matt. Matt had mentioned Pauline's presentation. I just wanted to make sure that we had taken advantage of that if that would be a way that you'd like to start the conversation as a privilege of having been a presenter.
Do I have a question?
Bonnie?
Okay. Yes, Pauline, thank you so much for your marvelous summary of the issues raised on the continent. It was really remarkable.
Well, I don't think there is room to go through all of them, because as I was listening to Matt, I was like, I should have mentioned that. I listened to Dave, I said I should have mentioned that, but it's impossible to think of everything that went on, or it's actually still going on, because COVID is still there, although not at as high as it was in those early days. But I was so overjoyed to hear Matt say that there was a long-term treatment for HIV. And I was hopeful that, I know it hasn't arrived here yet, Matt, but do you think PEPFAR will be able to support that? Because I think treatment became possible for HIV because of PEPFAR. And I don't know whether we'll still have PEPFAR. And then on COVID, Matt, well, I mean, I know it's a big question, but for me, I'm a little bit worried about some of the leaders who are going to be in the next government, as Imani was saying, and some of them are, don't support vaccines, and yet, vaccines have been lifesavers, and in the next administration, I think we are going even to have even a more challenging position to get the U.S. government to support anything, leave alone, COVID vaccines. What about other vaccines? And not only globally, but even within the United States itself. So my question, I guess, is, we have very little time with Biden, because January 20th, he will be gone. And I don't see us mobilizing ourselves that effectively to have him do anything before he leaves. But this is a question for all of us. What are we going to do to get the Trump administration One, not to get people who don't believe in vaccines in office. And then two, to, implement the TRIPS waiver that the US government committed to previously. Thank you.
Very well. Thank you, Pauline. Wonderful questions. Dave, we apologize for having to walk in front of either the projector or the camera to the room, but this is our setup.
Right.
We're living with it.
Thank you. Right. This is a question for all of us and for Matt as well. And that's, what shall we do? What are the specific actions that we should start taking? And this, one of the first questions is we are stuck in the House Foreign Affairs Committee with a boycott of reauthorizing the money for PEPFAR, which will have another coming from USAID, but conservative representative says that PEPFAR money is going to institutions and people in Africa who support abortion or whose institutions actually have been open to recommending abortion. So do we focus on that in the near term in the activist community? What do we do especially about the new proposal for the Patent Eligibility and Restoration Act? Senator Coons and Senator from Delaware and Senator Trellis, Republican from North Carolina, are proposing as a way to reinsure the proprietary hold on patent and intellectual property rights. And the Coons and Trellis, by the way, just happen to be very large recipients of drug company money for their campaigns, and are part of the conservative core that wants to reinforce the possibility of this super capitalism. And finally, what should we do actively about supporting the CDC's partnership for African vaccine manufacturing? How does this fit into the new model? And all of which is part of a bigger question for Matt. I hope you can comment, is what do we do to get to one of these models you've shown us here that actually maximizes the open production of the vaccines among those in the global South who have that capacity?
So several questions posed to you, Matt. I'd like to invite others in the room to add your questions to those that the panelists have put forward. We're happy to have you with us. And if you don't have questions, then maybe they overlap with what's already been raised to you, Matt. So please come.
Such an interesting panel, and thanks everybody for the thoughts. And I think that's really I agree, Dave, with your overall kind of overarching argument here, right? Which is that we've got to, like, this is a site where there needs to be activism, there needs to be much more movement building. And I think we as a whole, as HIV treatment reached as many people as it did, we relaxed, right? And we said, we figured out a model that will work. Famous people stopped dying, famous African people stopped dying, people in elite parts of nations around the world were no longer dying. And in fact, it became easy to be secret about your HIV status because it was just treatment, right? And so that's what we want, actually. Like, we succeeded in many ways. It's presented huge challenges because it means that those people that are kind of increasingly living with and dying of HIV are increasingly marginalized. So that presents a challenge. But as a global, like, movement, it meant we relaxed when it came to access to medicines. And then there was this kind of amazing thing that I think is just the height of neoliberalism in many ways, which was the invention during COVID of a global response that was in no way global and in no way an effective response. And we were unable to both see it and to respond to it, in part because it happened quickly, but also in part because it had the imprimatur of many institutions that some of us were part of creating, right? Where there really wasn't a kind of global movement against COVAX, because despite the fact that it failed epically. And in fact, the leaders of COVAX have gone on to get better jobs, right? And so, we don't interpret this within the kind of global sphere as a failure, even though it very clearly failed. By a year after vaccines were available, 25% of African health workers had had a vaccine, and 78% of all people in Western Europe had had a vaccine. That is what happened during a year of us vaccinating. That was the effects of it. So the idea that we created a vaccine equity effort and it did anything besides fail was just not true. So just on kind of the questions, I think a few pieces to say. So one is to Pauline's question. I am somewhat hopeful that we will figure out how to get these just incredible long-acting medicines to the people who need them. So as Dave was saying, I was in Nairobi last week, and turns out you can fly from Frankfurt to Chicago. So I'm like, I somehow figured out how to be in all the places. But I got off a plane last night. I was in Nairobi because the UN Joint Program on HIV was meeting and having its board meeting. And I helped put together a panel of folks to think about this, where there is an Egyptian company that actually can make it. There's been a license that's been issued to them to make the medicine. There's also an Indian company. We're thinking about how to get a generic version onto the scene. And we're thinking hard about how we get a few countries to issue a compulsory license. Because actually, if we can get a country like a South Africa or a Senegal or a Thailand or even a Colombia to decide that they want to issue a compulsory license, that will create the kind of political pressure that we think we need. So we've been working with governments to try to move that, because there is the money to purchase this. So there's a study out there that shows that these amazing breakthrough HIV medicines can be made for about $40 per person per year. Much like ARVs, everyone said here in the United States, it costs $40,000, right? Where I feel like I'm back in 2001. I swear to God, I gave this speech in 2001, right? In the United States, these drugs cost $40,000. Although at the time I said $15,000 because that's what they cost. So, but they can be made for pennies. Well, these drugs can be made for $40. So the actual making of them is not expensive. It's the question of how fast can we get the technology transfer, and will the patents stand in the way? And so we're right back there. We have to be able to do that. And so I am somewhat confident because that we have enough money to be able to buy them. To Pauline, your point, as long as PEPFAR doesn't get destroyed, which I'll talk about in a second, we can figure out how to kind of move that. So I think I'm somewhat optimistic, especially if there's pressure. On reauthorizing PEPFAR, I think we're in deep, deep trouble. So, I mean, this Congress, as I look ahead, the new incoming chairman of the House Foreign Affairs Committee has said that every single dollar that is spent by the US government should think about America first. That is literally what the new Foreign Affairs Committee chairman has said. That is not what PEPFAR does. So I think it's going to be very hard to get a reauthorization of a multi-year through. My hope, however, is that actually what is also true is that the way the US government works is that you don't have to have an authorized program in order for it to run. And so, the US domestic HIV program was for years unauthorized, and it continued through appropriations so that the funding continued to flow. It was just no longer guided by congressionally passed policy. And so it was up to the administration what to do. That is incredibly dangerous because of who is going to be, I think, in charge of the government. So I don't think this is a good news story in any way, shape, or form. But what it does mean is that we don't end up falling off of a cliff. And I will say that, of all of the people that have been appointed so far, Rubio is among those who believes that internationalism is a thing. I mean, I will say that I cannot make the argument for Marco Rubio, but and had I ever said to myself, boy, Marco Rubio is sure better than, I used to have a very short list and now I have a very long list. But I'm at least somewhat hopeful that there will be room to hold the money and then to hold the bureaucracy to account. And I think that is what we're going to have to do over the next 5 years, which is to pay attention to the money, pay attention to the funding. Does it stay there? And if it does stay there, can we hold the bureaucracy accountable for continuing to run a good program? Because hopefully most of the people who actually run the program, who are not political appointees, will continue to do their jobs. That is what I'm hoping. And then final two things I'll say is just on kind of open production. On the hand of very bad signs, I am God, how do I say this? Somewhat optimistic. I think the World Trade Organization, and this is a whole nother panel, I think the WTO waiver was a little bit of a red herring, in that it was amazing when the Biden administration said they were going to back it. I think they knew at the time that the Europeans never would. And the World Trade Organization is such a structure that it creates massively, I have a whole article about this, like it creates this massively difficult thing to insert a waiver, which is literally in law. Like it's in the trade agreement, it's in the treaty that founded the World Trade Organization. And so what happened is that the waiver ended up in this Byzantine process in which anyone could interrupt it. And so the Biden administration stepped back and said, go for it, we're in favor, good luck. And the Europeans said, we object. Well, Biden didn't fly to Europe and demand that it happen. He just kind of said, we're not against it. And so I actually do think that that should teach us something about trying to get through the WTO. That's my lesson this time, is that we need to get the WTO out of global health, mostly. Because as a venue for debate, low and middle income countries, and especially African countries, are disproportionately at a disadvantage, and instead move out into some of these other venues. And so I am super excited about the kind of mRNA hub in which South Africa just said, look, we are going to reverse engineer it because we have brilliant scientists. And now they're teaching folks in Bangladesh and folks in India and folks in a bunch of other places how to make the vaccine. And then the Brazilians have said, we have a literally state-owned pharmaceutical company. Which countries would like to build their capacity to do that? So that maybe in 3 to 5 years, what we have is a network of Southern leadership that is able to just say, we will, instead of being tricked into a COVAX next time, we will just demand access to the technology because we have factories that are built, we have networks that are ready, we have scientists who are standing by. And so the next political fight could be global South countries banding together to simply demand, all we want is the recipe. Give us the recipe, we will make it. And last time around, they were not able to do that. But I think people are being much smarter now about how do we build that capacity so that we can have that political fight in that way, because we're not going to win at the WTO. And for the foreseeable future, we're not going to have an ally in the United States government that's going to try to move things in a meaningful way. But even when we did, the Biden administration could have issued a compulsory license and shared the technology that was, to your point, entirely funded by the United States government. And they didn't. So I think that that tells us that what we need is serious solidarity of the type that I think like African solidarity networks have been able to do in the past, which is not imagining that the United States government is going to be a useful force in this space, but instead assume that it will be a block, and instead say, how do we build solidarity with colleagues on the continent who are fighting smartly to build things that are visionary, get behind them, and then figure out how to get our government out of the way and assume that our government in the United States will be a barrier, not a support. So that is my hope. Away we go. Thank you. Thank you all.
Is there room for comment?
Thank you all for coming. We're very pleased with the fact that we have this recorded and it will be available on AdNA's website, and we can use pieces of it for our advocacy, giving us the building blocks. Thank you to all the,
Horace hasn't come.
excuse me?
Horace hasn't come.
Oh, all right. I did not see that there was an additional question in the audience. Okay. Oh, a comment, please.
I'd like to come up to the mic for us.
Welcome.
Is it going to be available?
Yes, I did,
Okay.
and it will.
I wanted to thank the panel, but I wanted to make a comment about activism in relationship to health, and that the information that we had today demonstrates that we cannot separate health from immigration, from reproductive rights, from education, from employment, and from the military. And if we are to go forward with an ACAS, with any advocacy around health, such advocacy must include clearer guidelines for relationship with global Africa. And in this case, global Africa includes Cuba and the lifting of the embargo against Cuba so that the Cuban health infrastructure can be brought closer into the African health infrastructure to access WHO resources, and that the relationship between Cuba and Africa and Africans in the United States would be very important for the demilitarization of health, so that our advocacy should be in relationship to demilitarizing the bioeconomic warfare. Because what we saw in Ebola, in the evidence presented by the United States to fight Ebola, that it was part of what we call bioeconomic warfare. But I want to thank the panel for their.
AdNA is not the only sponsor of this panel. The Association of Concerned African Scholars, as Dave said, also, and we thank this longtime member of the Association of Concerned African Scholars for the comment. So with that, I will end the session, adjourn us, and with many, many thanks, Pauline, for you participating from Nairobi, Matt for making it here in person from Nairobi yesterday, Dave for your longtime leadership on and your interest in these issues. So we are very pleased that we had a good audience and excellent discussion amongst ourselves. Thank you for being here.